Welcome to everyone as you're entering to the Cochlear Center for Hearing and Public Health seminar series. We'll just wait a couple more seconds here to let everybody join us. Okay, excellent. So my name is Carrie Neiman. One of the core faculty members at the Cochlear Center for Hearing and Public Health, and we're continuing our seminar series today. I know we're at a little bit of a different hour and start time than we usually are, but we are very, very excited to have Professor McMahon with us today. So before we get too far introducing Kath, there's a couple things I want to just share as we get started. Okay, so in terms of just some basic logistics, for those of you who have attended our seminar series in the past, you'll know that these are familiar, but for those of you who are new to the series, please use the chat function for questions, and we'll go through those towards the end, but feel free to populate that at any point in time. We do have closed captioning available, and you'll see the link in the chat there. The seminar is being recorded. If you do experience any issues, please feel free to reach out to Jamie, and you'll see her email address there. She can help with any issues if they arise. Other things that we want to highlight in continuing the seminar series, we also have a research day that we host each year. We're really excited to be back in person this year. It will be April 25th from 8:30 in the morning to 3 p.m. Eastern time. The vast majority of the event will be in person, but for the talks, in terms of the faculty talks and our keynote speaker, there will be a virtual option available. There's a link that's been posted in the chat there, so please feel free to register. We'd love to have you join us. We have talks, you can see the bulk of the talks for the faculty are in the morning. Many of the core faculty are presenting on a range of different topics at the kind of the latest that's going on in each person's work. And then our keynote speaker is from 12 to 1 p.m. And it's Dr. Natalie Phillips from Macquarie University. She'll be speaking on sensory function and its relationship with cognition, brain imaging, and dementia. And we're really excited to have her join us. So we really encourage everybody to register and to join us. We're excited to be in person again. And yeah. With that, I'll go ahead and introduce our speaker today. We have Professor McMahon, who is head of the Department of Linguistics at Macquarie University. She's also the director of the HEAR Center, which is a World Hearing Forum member and an informal WHO collaborating center as well. Her research centers on understanding the barriers and facilitators to accessing and utilizing hearing healthcare, and the design and implementation of effective care pathways. Professor McMahon has worked closely with the World Health Organization to develop and collate the evidence base for really the World Report on Hearing, and she is also a commissioner on the Lancet Commission of Hearing Loss and is co-chair of the Innovation Service Delivery team that's part of the Lancet Commission that's working on that now. She is a dear friend to many of us, and we're very excited to have her with us today. So with that, I'll go ahead and turn it over to Kath.
Thanks, Carrie. Really lovely introduction. I really appreciate it. I'm just going to share my screen, so just bear with me. Here we go. And oops, we've jumped through. Just check. Sorry about this. There we go. And I'll just do a quick check again with Carrie. I'll just get a nod from Carrie. I'm on the right.
It looks like your personal view. So if you want to switch it to the presentation view and then.
Better?
Still the other view.
Okay, sorry about this. Just give me a sec. It did work before.
It did.
All right, here we go. So we'll start again. Oops. see how we go. Why am I? Okay. Oops, and I'm assuming that it's still I got to swap the display, is that correct?
Yeah,
okay.
correct, yeah.
All right, here we go.
Looks great.
Great, thank you. Thanks again for the really warm introduction. It's a real pleasure to be here with you. And I wanted to start this morning by, this morning for me, this afternoon for you, by acknowledging the traditional owners of the lands that we're all on today. For me, I'm on the lands of the Gadigal people of the Eora Nation, and just pay my respects to elders past, present, and emerging, and also to really acknowledge how well and effectively Indigenous peoples have looked after the lands, the waters and the air for us for many, many generations. And in Australia, we have some of the oldest generations of Indigenous people in the world. But what I'm talking about today is hearing healthcare in adults. Oh, I've got the wrong, I have the wrong title on this. So I am just going to, I will stop sharing because I just realized that this may well be the wrong PowerPoint presentation. Here we go. I'm not sure why we are now in the wrong presentation. One sec. I'm just going to keep talking while I put this up because I think this is, here we go. This is important to get an overview of the why I'm interested in hearing healthcare for older adults. Of course, with hearing healthcare being in adults being a major population health need, this is something that I'm passionate about addressing. Here we go. All right, I must admit this is the right presentation. I just have the wrong title slide, so I'm just going to pop it on one more time. Yeah, passionate about addressing, and in fact, my research also is within the space of Aboriginal and Torres Strait Islander hearing health. Again, another major population hearing health need in Australia. Both are uniquely distinct and different, but both need the same sort of approach to really address some of the challenges that we see. And I know from the work that I've done with Carrie and team that the approaches are very similar to the ones that are used within the Cochlear Centre and within the team there. So really, this is about the increasing burden, if you like, or the growing numbers of adults that have, or the growing number of people in the future that have got age-related hearing loss. And I know that many of these graphs are familiar to you. This is one that's from Australia, but it looks similar. It doesn't matter where you are in the world. Age-related hearing loss increases with a function, very clearly with a function of age. And this is just showing the different proportions for mild, moderate, and severe, really showing that by the time that one is, 85 and above, the vast majority of adults have a hearing loss. However, the prevalence of hearing loss, and this is a graph from the WHO, of hearing loss in older adults, is influenced or impacted by, social determinants of health. And certainly this is the average gross national income per capita shown here. And you can see where different countries sit along this curve, where those that have lower average GNI per capita have got a higher risk of hearing loss within older adults. But that aside, there's still a significant proportion that we're looking at within high-income countries that really have significant barriers to accessing hearing care. And a lot of the, when we think about concepts around access, a lot of our focus is really looking at access from a supply perspective. But in fact, for older adults, and certainly for the work that we're doing with Aboriginal and Torres Strait Islander people, a lot of the barriers around the demand. That is, it's either a demand issue, it's a demand challenge because older adults are not seeking help, they're either not concerned or there's stigma around it. Whereas for Aboriginal and Torres Strait Islander people, we have really significant racism in the sector, and we don't have a service that's tailored for them. And when I consider the research that I'm doing in these sort of two broad arms for older adults and for Aboriginal and Torres Strait Islander people, it's really clear that the system that we have is not a system that is desirable. It's not a system that's accessible. And in fact, a lot of our framing is around the device itself. And I guess throughout this conversation that we're having here and the presentation that we're having here, my questions are really around, whether we can improve the system design, whether we've got it right, or whether we've sort of inherited a design that really is, it's historic in the way that it's been developed. It's very pragmatic, and actually it's not particularly effective to be able to do what we're trying to do, which is to ensure that people can access ear and hearing care within a timely manner. So the first access is timely, and then they're very effectively connected to care. I'm not going to talk much about this because, of course, this is very well established in the team at the Cochlear Centre, and Johns Hopkins has done some really beautiful research within this space. But as we know that, the imperative for older adults, or the burning platform that we have at the moment, is the work that was done in the Lancet Commission on Dementia, and the work that has really been spearheaded by Professor Lin and the team there. So, it's really the fact that we've got this strong association between hearing loss in older adults, or even hearing loss in midlife, which increases the risk to dementia in later life. But as well as that, we know that there's increased healthcare costs and there's broader economic costs to society. So if left unaddressed, we have got this major burden that somebody has to pick up for our older adults. And we don't have good participation in society, because really that's what we're trying to address, is that all members of society and civilians within countries can really participate effectively. And, that's really what spurs economic growth, and social connectedness is critical, if not the most important thing in our lives. And then there's also very clear evidence of hearing loss being associated with increased mortality risk. Some of the work that I was doing very early on was actually working with some key colleagues of mine to develop a background paper for the World Report of Aging and Health. And I actually met the technical officer of the team that led of the person that led the team for aging and health, who was an Australian medical researcher. And he was really passionate about the fact that they within this report, within the World Report on Aging and Health, that they developed this new approach, or this new model to the way that we should look at aging. So I'll just briefly talk about our paper. So our paper really looked at aging and health across a life course, which ended up being sort of the life course approach really was that foundational piece that was the thread through the World Report of Aging and Health. It's very important. What it basically says is that across your lifetime, that you're accumulating, that you can accumulate different insults, if you like, which then contributes to the outcome as you get older. And so it's really looking at a life course perspective, so you can see much more clearly then where the points are along one's life course to intervene. Where are those high impact points where if you intervened at this point, you would actually then be able to mitigate a considerable impact later on. But what was presented as being sort of one of the most revolutionary parts of the World Report on Aging and Health, if you like, is this idea that there's a difference between functional ability and intrinsic ability. And I think for a very long time, we really have looked at, and we should still, intrinsic ability. But actually this marker of functional ability was really critical, because we know there's incredible variability for people that might have the same intrinsic capacity, so same measurable levels of hearing loss, same measurable levels of vision impairments, same measurable, whatever function you seek to measure, that while two people might look exactly the same on those metrics, their ability to function in society could be vastly different. And so there's this deviation, if you like, between the two. And this is a life course model as well. So of course you start with high and stable capacity, where functional ability and intrinsic capacity are quite similar. And then through midlife, we have a further deviation between the two with decreasing capacity. And then, if you like, towards the end of life, we've got a substantial loss of capacity, and then we get a significant deviation, particularly towards the end of functional ability and intrinsic capacity. And I think this is really important. And the reason I want to speak about it today is because the research that we've done has started to really highlight, what are some of these differences? What are the ways that we can start to look at it? Why, it shows why it's important. So I'll come back to it throughout the talk. I just wanted to also put forward, something that I think is really critical, that to solve a lot of the challenges that we have, I just wanted to talk a bit about the system. We, for a very, very long time, in fact, since really ear and hearing care has evolved, and hearing care in Australia probably very similar to hearing care globally, well, not globally, certainly in high-income countries, developed as a result of World War II, right? So it started first in World War II, where we had a bespoke service that was dedicated to addressing the vast levels of hearing loss in men who were returning from the war. Now that extended with the rubella epidemics that we had, where we had lots of kids then that were being born with hearing loss. So the service then extended to kids. And now in Australia, we've got this very well-established hearing service, government-funded hearing service, that still manages adults. But so what it does is it provides for older adults who are on the aged pension. And it also provides for young children. In fact, that was recently extended to provide services up to the age of 26. And the reason this is important is to give kids their very best start in life, right? So that it's fully funded, it's a fully funded system. For older adults, it's a funded program that provides what has often been called basic hearing aids and basic care. But in fact, when we look at the level and comparability of the types of hearing aids that are provided, it really is a gold class, high standard system of care that's provided by the government, with the option for older adults to be able to top up. So that is, if they choose to have something that is outside of the government services program in terms of hearing devices, they can, of course, and they can just pay a top-up fee for that. But really fundamentally, hearing services have sat side by side, really quietly, really nicely, but not effectively with primary care and primary health. And it really hasn't. It's been very interesting to see that for some reason there's a real barrier for GPs and primary care providers to pick up ear and hearing care. It's a real challenge. It's a real problem, and it's a global problem. I speak to some of my colleagues who are GPs, and there's still this well-held belief that if you can design something that's better than the hearing aid, then of course I will send them to you. So there's a belief that hearing aids are not sufficient, not effective. So this is something we definitely need to turn around to demonstrate the evidence base that's beyond that amazing paper that Mel Ferguson and colleagues did from the Cochrane Review, but really does demonstrate the effectiveness of not just hearing devices, because I think we pin our hopes on technologies too much, but really the service and the care that is delivered alongside that. So the World Report on Hearing, the main message, the one main message that was really delivered from the World Report on Hearing, that's got beautiful diagrams and lots of really great information, but the one key message is that countries must act to integrate people-centered ear and hearing care within national health plans for universal health coverage. And what it's calling out is, ear and hearing care is not distinct. It is not unique. It should not be on its own. It should not be in parallel with health. It should be effectively and very well embedded within national health plans. Because why is it that, you know, you can go to a health check and a life check in Australia and you have everything else checked? You have vision checked, you have your heart checked, you know that you have all other capacities checked, but you don't have hearing checked. It just seems to be it seems to really stick out. And I think that that's one of the things that we don't want to design a system that is bespoke and unique and only addresses ear and hearing care, but we want to design a system that's got really strong links with health. Because I think, you know, if you can ensure that you're bringing these two systems of care together, we really have been thinking of hearing care has really been in the social system side, so around disability, but bringing it together and integrating it within health, I think will be a game changer for all of us. I want to talk a little bit about our experiences in Australia. So there have been attempts to really look at driving more people into the existing system that we have. So, you know, I've sort of put a really fundamental system up on the screen here. So we have, you know, you can have screening or detection that brings people into the current system. And the current system, which is a really common system globally, is that we diagnose hearing, we diagnose the challenges people are having with hearing, we fit hearing aids, which is a really we talk about it being, you know, a core component of the rehabilitative service, but unfortunately, most of our metrics are around the success of the device rather than actually being around the successful outcome for the individual. And then we have a follow-up and review to make sure that everything's fine for the individual. But there's now quite a bit of emerging evidence to say that it's, you know, and there's a well-held acceptance that this framing around the device itself is probably not enough for many people, probably absolutely fine for a proportion, and probably not enough for a proportion of people as well. And I think that we need to really start to look at the services provided and the opportunities to be able to address it so that we don't have a single model, but we have really clear pathways for different people who might choose to have a different route, if you like, a different choose your own adventure to get to the successful outcome that they are, that they need in society to fully participate. So the experience that we had is that, like many, there were a number of countries that were looking to implement screening tests for hearing for older adults, and some have been successful and some have been not so successful. So Harvey Dillon, whom many of you know very, very well, he was the director of NAL for years and years, and he's done a lot around hearing devices and prescription, developing, you know, prescription formula. What he did was he developed a digits noise screening test that you could ring a phone number and you could get a free screening test where you're just identifying the right digit within a noise environment. The noise is modulated up and down depending on what your answers are, or depending on whether your answers are correct or not correct. It's got high sensitivity and high specificity, so it's very, you know, it's a very good tool. But so the tool was released, and then Carly Mayer and colleagues. So Carly works very closely with Louise Hickson, who's also very well known within audiology within Australia. And with Harvey and colleagues, they evaluated the outcomes of this program, the TelScreen 2 digits in noise screening test. So they investigated 193 participants who failed the test. They did a telephone interview 4 to 5 months later. And of those, 36% had sought help. There were 8 hearing aids fitted, 6 had a successful outcome, and hearing screening by telephone improved the outcomes for 5% of people who failed a hearing test. But the interesting thing was, for some of the people who failed the test, when they had a follow-up, they reported that there was no problem, that they had passed. They didn't remember the outcomes. And so there's not this real sense of process of, you know, there's a problem, I must follow it up, and then I must have something done about it. So there is sort of this, there's this low perception of need to address a hearing problem. And, you know, I do believe it, and perhaps this is blind faith, but I do believe that if we have consistent messaging from health all the way through the pathway, that, you know, if we were able to achieve embedding ear and hearing care into national health plans and into primary health, that the messaging really does start, the messaging about caring for your health and doing the right thing does sit with the GP. It starts with the GP. Certainly in Australia, systems might be different in terms of what information people believe, but even if it was up on government websites, so whatever the means, consistent messaging about the importance of hearing care across the life course is critical for people to care, to take action, and to really, to choose a path that enables them to be able to seek help and to then and to participate well in society. So these are really important concepts, I think, that need to be discussed. So even when people have hearing aids, this really is looking at what the literature says at the moment in terms of in different countries, and these are, vastly, really looking at some of the high-income countries here. What is the prevalence of people who have hearing loss who then will uptake hearing aids? And it's really clear that it's, it's at best, it's sort of like 1 in 3, and that's for an older population. So at best, we're looking at 1 in 3 people who uptake hearing aids. And then Harvey Dillon looked at this Welsh National Survey, which is done in regular intervals. And what he identified was that even if you have a hearing aid, it's not a marker of whether you wear it. So this is, I appreciate this is not new to all, but it is important to start recognizing that we're pinning our hopes on technology hearing aids. We're looking at access to hearing healthcare around hearing aids, and we're looking at the success around hearing aid use as well. And so the framing of what success looks like is really important. I think that hearing aids as a marker is a critical marker, because I think in the absence of anything else, we really need to understand what uptake looks like, what success does look like. But I think we probably need to start looking at broader markers of outcomes. Brent Edwards in 2020 put forward a new model. I haven't yet translated this for the US, so just bear with me, but I assumed that you might be able to translate it yourself if you could think about the population in Canada. So really what he was doing was he was calling out this concept of unmet needs, and he was looking at those with no measured impairment and those with measured impairment, using a pure tone average of greater than or equal to 25 dB across 4 frequencies. It's a really common metric around unmet need. And then he divided it into a quadrant. And so on the vertical axis, then he looked at, well, then what does it look like if we have perceived difficulties? So perceived hearing difficulties using something like, for example, a hearing handicap inventory. So then it could be divided up even further. And there's a category of those people, or there's a quadrant of those people who've got no measured impairment and no perceived hearing difficulties, which sit here. Now, these people, we acknowledge that they probably won't come across ear and hearing care for some time. They probably are those younger people, the youth. But in fact, when we're looking at the trajectory of change, if you like, or where the WHO has got their eye on, they're really focusing in on those people who are subject to loud noise and may well have hearing loss in the future. How can we mitigate? How can we reduce the proportion of people that have got hearing difficulties or hearing loss in the future? And the WHO really have got their eye on how can we have people reduce the level of noise and sound that they're exposed to regularly. We've got a considerably high proportion of people that sit within this quadrant. We probably, if we're looking at developing solutions for these different populations, we probably don't want to leave them out, right? So we probably still want to continue down this path of really looking at what are the ways that we can ensure that people are embedding good hearing health practices in their life so they don't then move towards a later trajectory of having a measured impairment or perceived difficulties. There's a population that got a measured impairment and no perceived difficulties. And in fact, I was reading rereading a paper the other day it really was looking, it was from the UK, and it was identifying that there's sort of like 40% of people have got measured impairment and no self-reported difficulties. So there's, whatever the proportion is in terms of those that have got measured impairment, so this category here, there is a significant proportion that report no difficulties. And I'm going to talk about a qualitative study that we've just done. I'm going to show you a few results, but I've obviously not released all the results here today because we're in the process of finishing this thematic, the thematic analysis, and then we'll publish it. But I think it's important to really understand there's this sense of, there's a strong sense I get when I speak to researchers and clinicians that the people here that have got measured impairment and no perceived difficulties are just in denial, and that we should be doing something for them. But with the study that we've done, my greatest sense actually is that they're actually not in denial. This is the difference between intrinsic capacity and functional capacity. This is the difference between people having a measured impairment, but in fact, there's many things in their life that enables them. And enablement is really important, and how we can improve enablement in our societies is really critical, I would have thought, to reducing the burden of hearing problems without necessarily going down the path of the device, which is very individualistic. It puts all of the responsibility on the person that has the hearing problem. There's also, interestingly, people that have got perceived difficulties, about the same proportion of people that have got measured impairment and no perceived difficulties that have got no measured impairment based on a four frequency pure tone average. But they do have perceived difficulties. So if we look at the HHIE, anything above an 8 on the HHIEA is considered to be mild towards too severe perceived hearing difficulties. And this is something that I think we should pay attention to. How do we address hearing loss, or hearing problems, I should say, in these individuals? This is a critical question, because having had a number of people now who've shared their personal stories with us, it is clear that when they come to a system, so an ear and hearing system, and they are told that there is nothing that can be done because the only solution that we have is a device, it worsens the problem. There is no other pathway, there is no other solution. So it really is, they get, if you like, they come into, if you think of it as a system, they get bounced from the system. So they're trying to come in, they really want this address, but they get bounced out. And that creates additional burdens on their mental health. And then there's this group of measured impairment, perceived difficulties that we've done a lot of work over the, not we personally, but many people have done a lot of work over the years to really understand those people who have measured impairment. They've acknowledged that they have hearing difficulties, but they don't have hearing aids. And of course, we know a lot about those people who do have hearing aids. And the question has always been, how can we move this group of people into being this group of people here? And if you can move them along the pathway and through the system, then in fact, they can then have the care that they are seeking. And so these are really important system questions, because the question becomes, how do you design a system that addresses the need? And it's not just unmet need by looking at measured hearing impairment, it's what are the true needs of a population. Just going to talk about a few studies that we've done. I'm mindful of the time, so I just wanted to leave some time for questions and answers. So I just wanted to talk about, we did two studies. One was barriers and facilitators to hearing healthcare. So we looked at 4 different cities in 4 different countries. So the systems were remarkably different. So London, at the time that we did it, it was fully NHS, but government-funded system. Seattle was, for the people that we interviewed, was a fully user-pay system. So we didn't have any vet people that came through the interviews. And then Toronto and Sydney both have hybrid systems. That is, that the government contributes to the hearing care. It's different in terms of how they contribute. But we had people in all of these, we had people within all of these cities that fell into different groups, and some said that they had no hearing difficulties, but they were over 60 years of age, and so we were speaking to them, in terms of their hearing difficulties they'd noticed in friends and family, and also their own perception of developing hearing difficulties later in life. We had those that had hearing difficulties without a device and hearing difficulties with a device. So for all of them, we sort of stratified them into these, a cluster of 12, but we did sample across these different groups and had fairly similar numbers across these different groups of no hearing difficulties with or without a device. So again, I've got a system, which is a very pragmatic system that's been put up the top, and I just wanted to put through what are some of the key things that came out of that. And I won't read the quotes, but the key, so please feel free to read them. But very much we heard that there was this balance between social emotional awareness of hearing needs for individuals, the impact of effortful listening for individuals, so this constant tiredness and fatigue, and the social self-stigma. So it's really, this experiences that they have, that they are balancing multiple things to try to determine whether to seek help or whether not to seek help. How bad is it? How much will I gain? And so we really saw this cost-benefit analysis that was going on for individuals, where the cost was not financial necessarily, but it really was this balance, that they were this weighing up of whether or not it was worth it for them to address the hearing problem. Was it worth it for the individual and for their families? And often the tipping point was really clear. So it really was, there's this one point in their life where it was recognized that actually I missed that, and that was really important to me. So high value, conversational, high value places that people would go, whether it was places of worship or whether it was to see grandchildren. There was definitely this sense of, I did it because of X. It wasn't necessarily, everything in my life. It was typically a tipping point. We often speak about this in Australia, and we heard it in Australia, Canada, the US, and the UK, which we found really interesting. It was that we have low levels of trust in the system, and there was, interestingly, a lack of an authority figure. Who's in charge? Who should tell me what to do? Certainly if it's not coming from the GP, then it's a problem. There's choice that is embedded within all systems, right? So should I go, is it a better hearing device, which is what I'm seeking, if I go to private? Or do I just go for the stock standard? Do I just get the basic care? So again, it's this sort of private, public provider weighing up what's the cost versus the benefit that I get. I will read out the one from Canada, because I think these quotes actually were very representative of what we heard. If you go to the dentist and he tells you need a root canal, you have a root canal. If you go to the optician and he tells you that you have cataracts, and you have them fixed, but there's no authority figure for hearing. I think it'd be helpful that you have to be told this is what you needed to do, not sort of secondary from a relative. So it's a sense that, there's no continuity of information and messaging that comes from health all the way through. And certainly there's no figure, they can talk a little bit about what they thought an audiologist or audiometrist, we call them, was. They couldn't really tell the difference. And it was very blurry for them about who they should listen to. Again, this is around the technology. So the value of hearing healthcare is defined by the cost benefit of hearing aids, not the care that's received, not the outcome that we deliver. And I think this is really important, because obviously it's a really clear point that can be addressed within care. It's just not, I think often people will leave a service with this sense, and I've seen many articles that have come from the US as well. It's the idea of bundling. I think that the sector is very hesitant to unbundle services for very many reasons, because of the financial model, et cetera. But this sense that my hearing aids cost me $10,000, whereas in fact there are service costs and professional costs that are embedded in that. But it devalues the service, and it devalues the professional that's delivering the service. And that it's a problem, because again, from the previous comment around there being, or theme around there being no authority figure, we're devaluing the authority figure as well. We also looked at this with cochlear implants. So I'm just going to very broadly show you. This was we just reduced the scope. It was a different part of funding that we had, and we looked at London, the UK, and we looked at Sydney. So again, we've got this government-funded system, and we have a hybrid system in Sydney, in Australia, for cochlear implants. Sorry about the noise, but for cochlear implants, vastly government-funded. Okay, enough. So we had 26 adults with a hearing device. We had 7 GPs and 21 audiologists who participated. And again, we're looking at focus groups. So it's a qualitative research study design. I've actually added in a piece here because I sort of added it in. I think that there's another piece that we don't really talk about very much when we take a pragmatic system, and it really is we have screening and detection, but actually there's this socio-emotional awareness of hearing limitations, and that's the tipping point. This is the important point, if you like, that brings people into the pathway. I don't think screening does, from what we've seen. Screening alone is not enough to bring people into the pathway. And there are challenges in the pathway as well. So we've got diagnosis, hearing aid fitting, follow-up review for the hearing aid pathway. Now, interestingly, in Australia, probably similar to the US, but I'm not really sure. We have different providers that provide cochlear implants. It really is a multidisciplinary team. It's really embedded in we've got lead ENTs that are part of this. The service is delivered differently, but we end up then having this, if you like, bridge between hearing aid delivery and cochlear implants, and it's such a disincentive so now we start to see the disincentives to the practice that we have. One is that when hearing aids are the focus of what we do, keeping people within a hearing aid pathway and keeping people with the same service provider is an incentive, financial incentive for the individual who is managing their care. If we had focused on outcome measures, then in fact it would be an incentive to pass them on, because then moving into a cochlear implant pathway where the individual would benefit more would provide access to timely care. There is such a bridge here that it takes often a very long time. So, on average, it takes about almost 10 years. There's good research now that shows it takes almost 10 years for individuals to identify hearing problems to access this pathway. But this gap, it's never been quantified, but we know that there are so many people who could benefit from cochlear implants who never reach this next stage. And we can see now all the disincentives to it. Let me go through the themes here, and we can talk a little bit about, well, how can we address some of these challenges? The impacts on the individual and their social identity is far more profound as hearing loss is greater. That's, the language that is used. My hearing impairment has greatly affected me emotionally, and I felt that people thought I was retarded. Like, there's really strong language that's used around this. Was clear to individuals. So we have people who are going through the pathway, have gone through the pathway. We've got audiologists and we have GPs. And it's very clear from everybody's perspective, and we have a perspective here from the audiologist and one from the cochlear implant candidate, that there is fragmentation in the pathway. There's poor information and there are major knowledge gaps, so that individuals cannot move seamlessly from one part of the pathway to the other. Like, this should not even be visible to participants or to patients or to clients. This should be a seamless pathway where everybody's focused on the individual's outcomes. So I just want to turn our minds then to the way that I have been looking at this, and actually then to show you some other research that we've been doing that really does start to further highlight some of the challenges with looking at this. So what I put up before was this very pragmatic system. That is that we understand the system. We've got policies around it. It's very clear what it is and what its scope is, right? So we in some cases have screening or detection that aims to bring people into the pathway, or there's a trigger that brings people into the pathway. The hearing care or hearing aid pathway, if you like, is very, very well defined. as is the cochlear implant pathway, but there's a major gap between the two. These system elements are the way in which we've been looking at what the barriers and facilitators are to getting people in and to moving people across pathways. However, the lens that individuals look at, and so we've got research here, and it really is around the experiences and perceptions. So it really is about them, how they're feeling, their social and emotional awareness. So the questions we're asking around the system, we're getting responses that are around, but this is what the impact is for me. This is what I am balancing every day, right? I'm balancing my hearing needs by virtue of thinking about how hard this is to listen, but also the stigma around both having a hearing problem, but perhaps even greater stigma around having a hearing device. They are looking to seek trusted information, like how do they access this trusted information? Who's trusted? Who are the healthcare professionals they should be asking? It does such a disservice to not have ear and hearing care embedded in health, because that's the start of the pathway for many people in all aspects of health. The next part here that I'll just briefly talk about, the acceptance of loss and device uptake really is a social identity shift that many people are undertaking throughout this path. And I don't think that there's no opportunities for us to work with individuals to assist them to shift for that social identity shift. Whether that happens from the first port of call in a GP's office or whether that happens in an audiologist's office. I think that when audiologists start to see older adults, there's this sense that they've arrived in the pathway. So our job is to really sort of bring them along the pathway rather than to address some of these psychosocial really big issues that they are facing about their identity and how this is changing. And of course, this is even greater for those people that have cochlear implants. And some of the work that I've done, fortunately, allows me to speak a lot to teenagers or to young adults who have been through the journey of newborn hearing screening, and now they're at a point where they're moving into into the workforce or into higher education, into tertiary education. And some of the stories they're telling me really reinforces this notion of in terms of their identity. So in Australia, we've got this amazing newborn hearing screening program, but mainstreaming of children into classrooms has been a really important outcome of what we do. And sorry, my daughter's just off to school. See you soon. And so this. So what they tell us, so we're really proud, from the perspective of success, we're really proud that the system has worked and that all of the checkpoints are providing opportunities for these kids to be in a normal classroom. But for them, they could be the only person with hearing problems in the whole of the school, and that defines them. There's defining components about having hearing problems. That's important to bring people together, bring teenagers together through those social adjustment times, so they can talk through their social, the impacts on how they see themselves, how other people see themselves. And I don't think we do this very well for older adults either. And then, of course, if people have taken up a device, then there's their own ecological evaluation. That is, how does it perform within my everyday life? Is it still of benefit to me? Does this provide me with the benefit that I need? And then there's acceptance or rejection of the device. But still, within these experiences or perceptions, we still really, I don't think, have done good and due diligence of addressing the psychosocial challenges that individuals have. And the question for me is, how do we do that well? We've also just published, so I had a fantastic, really fantastic Masters of Research student who will go on to do a PhD, who's been working in the cochlear implant field for many, many years. She was a mature age student that went into the Masters of Clinical Audiology program with us, and then very soon after she finished, she then got a job with a a cochlear implant organisation that supports and provides services for young kids that have got hearing problems. That's the Shepherd Centre. And then she moved to Cochlear, and now she's back at the Shepherd Centre. But she's done some, I remember her telling me at one stage, which is, wonderful to hear as a lecturer who teaches anatomy and physiology. She came back to me and she said, all the stuff that you taught, we actually don't need it, really. We really just need to know how to speak to families and how to really provide the care that we need to provide for kids that have hearing loss. Anyway, I've turned around. She now knows that anatomy and physiology is really important. But what she looked at was all of the assessments that we have. This was a systematic scoping review. She was looking at what are the assessments that we have that include measurements for hearing and for listening. And it's really clear that a lot of them really are looking at, they're very functional outcomes, looking at word or sentence, perception, or the ability to discriminate between words or perceive sentences. There's detection-based responses, but there's not a lot around, there's self-report measures, but there's sort of not as much around the linguistic measures, because of course what we're trying to do with the vast majority of adults that have hearing aids is that we're trying to offer them opportunities to communicate effectively, and we don't really measure it. So this is an important piece in the way that we're looking at it, and piece in our puzzle. Okay, so what we're looking at now, just to briefly recap before I go into the next piece very quickly that we did, is that we've looked through the lens of system elements, but we acknowledge the experiences and perceptions. Just quickly, I want to get back to this study that we've just done. We haven't finished it yet, but I just wanted to start to talk about it, because I think this is really interesting what we're finding. Again, we've got this quadrant perspective, and I just wanted to show that we've recruited 10 people into each of the categories. So into this category of no measured impairment here, perceived difficulties. In fact, we couldn't get 10. We only could get 8 people in this category. 10 people into this measured impairment, no perceived difficulties. They were easy to get in. They often went to have a hearing test when their partner had a hearing test, just because they were offered one and were surprised by the result. And then we've got this category here, and the red dots are actually those people that have got hearing devices. And interestingly, you'll see that one person in this category did actually get a hearing device, and one person in this category did actually get a hearing device as well, even though they felt they had no perceived difficulties. But we did a thematic analysis of the data, because we were really interested in what their perceptions were of their hearing impairment, of their the difficulties that they had. I'm just really going to talk about. I can't see for the bar that's up here. All right, here we go. I'm just really going to talk about those that had hearing loss but no hearing difficulties. So this category up here. Because I think this is really important. It's important to me because when I read articles that have talked about unmet need, they really focus on this category quite a bit. They focus on two things. They focus on this category up here, those people that have got hearing loss but no hearing difficulties. And they focus on this group here, those who have got hearing loss, hearing difficulties, but don't yet have a device. I agree that we need to really focus in on this group, because I think that there may be barriers in there, which is not just barriers around stigma. Well, it is around stigma, it's around stigma and social identity, and I think that some of these may well be addressable where they've recognized and in fact their partners recognize they have hearing problems, but they haven't yet moved to the next point of doing anything about it. But this group here, the more I hear them talk about what the challenges are that they have, the more I'm surprised at how much we haven't believed them. They don't have hearing difficulties. Their communication partners don't see them having hearing difficulties. And everything that they say suggests they don't have hearing problems. And yet we keep assuming that they're in denial. I'm not sure they're in denial. I think that we should accept what they say. What we're getting, and of course it's a small study. It's not representative of a population, but I do wonder whether we are misconstruing the information that we get, that just because people have got a measurable hearing loss does not mean that they necessarily have hearing difficulties. And it gets to that difference again between intrinsic capacity and functional capacity or functional outcomes. So, I honestly haven't noticed I have hearing problems. I'm not aware that I'm missing out on anything. I was surprised that there was something so measurable there. Okay, they also, just trying to move to the next one. And just one sec. Here we go. They have also normalized, their hearing loss by noting that they've lived with a partner that they mentioned have greater hearing needs than their own, or the same as others, right? So, my husband has a hearing problem, I don't. If there's a lot of noise around, I've got a partially lip read or really hear, but yeah, I think maybe a lot of people have that problem. So again, they're really not having problems, but when we're challenging them constantly, they're providing explanations. They're providing alternate views about why that might be. What I want to talk about now is that we have this group here. So this is a group which I think will be, and it's one that Brent Edwards and colleagues are currently looking at, but it's one that's really a tricky group, right? So these people that have significant hearing difficulties, but that they don't have a measurable hearing loss. How can we help? How can we help? So they ignore that. So they're talking about ignoring people, interrupting conversations, withdrawal from social situations. I'm not introverted. Well, I am a bit. I just stick to myself more. But importantly for this group, they seem to be those that where it has the greatest impact on well-being and therefore on health. And it's not clear to me, because of how small the study was, whether these are people who come in with additional, whether they are naturally anxious people, for whom, where there's a slight change in something, where they may have some level of hearing loss, because of course it's the pure tone average, that it does impact on them, right? They might be really sensitive to what their hearing needs are. But these are definitely people who talked a lot about the impact of the hearing difficulties on their well-being. It could also be that they've sought help, and that when they were pushed out of the system, that this has had a major negative impact on them. Okay, I realize that we're out of time. Okay, determining the way forward. I just want to talk about, so one of the things that I spoke briefly to Carrie and to Frank about when we first got on is that, I started in this area of work many, many years ago, because I truly believe that it's a major area that needs to be addressed. But when we looked at doing co-production, so I truly believe we need to work with people to design systems for who they're supposed to be designed, right? The Lancet Commission on Global Health in 2018, this is exactly what they're talking about. Health systems must be designed for the people that they serve, right? Because that's what we want. We want to make sure that people can come into health systems. So we put this group together to do co-production, and they ranged over age, and they ranged over devices, and they ranged over hearing problems. And there are some pretty profound quotes. One of them was, they're just not listening. They always think it's black and white. If she has a hearing problem, she needs a hearing aid, but it can be subtle. Like, the issues that they have can be subtle. What it made me realize, though, is that it's really hard to bring a population with the diversity that we have with adults together and try and design a solution for them. And so some of the work that, Carrie's working on now, where there's a culturally, linguistically diverse community that's brought together, solutions can be defined, right? There are design. So thinking about how we might design the solution becomes really important. I think we need integrated care, trusted information, we need better awareness, we need better technology, but I'm not harping on the better technology, because I also think that we need accessible environments. I think there's lots of people that are really looking at this better technology. For me, I just want to build a system that works for people. I just want to finish off by saying that the WHO has put forward a hearing screening program for older adults, and they're really clear that you need both the metrics around measuring hearing, and you need the metrics around whether people have hearing difficulties. And I think it's really important. I think we need to build a system that really looks across the system. Where are the barriers? Where are the enablers? We need expanded access, and we need trusted information. We need informed decisions. We need people to come in to make their own decisions, but they need good information to do that. We need a much better assessment of need. You know, we can't rely only on the Pure-Tone audiogram. We need to understand what success through the pathway looks like for individuals. We need more solutions, not just hearing aids, and we need better care pathways so that the issues with social identity and the shifts that need to be addressed are being addressed through partnerships with community sectors and with health and with hearing care as well. I think all these are really important. So on that note, and I realize that I'm just on time, I'd like to thank you all for coming. I will stop sharing and hand back over to Carrie. Thanks, Carrie.
Wonderful. Thank you so much, Kath. I know we are just at time, but if we maybe do one question before we jump over. There's just a question about, there's a number of questions, but we'll talk about one in terms of the qualitative work that you spoke to, and you stratified by the different countries that you looked at. And you spoke to just the diversity that exists between all of these populations beyond just, you know, the countries of origin. Was there any analysis or exploration of some of the other kind of social constructs in terms of things like race, ethnicity, or their history of formal education, or things like that that went on in those particular analyses?
Yeah, it's a good question. By virtue of it being a focus group and a qualitative analysis, it was explicitly small, right? So we had 12 people in each group. What we've done since then is we've actually rolled out a broader survey. We've developed a survey tool, so a broader survey. So we now have the data for 1,000 people in each country, plus an additional 500 people who also came in. So we've got the survey instrument for 1,500. Of which 500 have also come in for a full hearing test. So we've got the ability to now make much better, draw much better conclusions that really starts to look at diversity in terms of geographical, you know, where people live geographically, in terms of cultural diversity, in terms of age. So it's a very good question. The answer is no for the qualitative piece by virtue of the fact that we were only able to bring in a small number, but it drove the development of a tool, a survey tool.
Okay, excellent. With that, I know we are close on time, so we'll go ahead and wrap up today's session. Thank you so much, Professor McMahon, for joining us today. And please all to remember to sign up for the Cochlear Center Research Day coming up on April 25th as well. And yeah, wonderful. Thank you all for joining us.